Alright, we've now talked about a bunch of different kidney concepts, including some fun equations. This next slide is the bread and butter of understanding kidney physiology, the nephron. This is very important to know. Let me repeat that. This is very important to know. You might see questions that ask you about this material directly, or you might see questions that ask you about how this material is affected by hormones or diuretics. All in all, please focus on this material and make sure you master it. Let's start with the proximal tubule. The proximal tubule is where the bulk of reabsorption takes place. The biggest mechanism for doing so is co-transport with sodium. This mechanism allows for reabsorption of glucose, amino acids, and even bicarbonate indirectly. Water is absorbed isoosmotically in this area. This segment accounts for approximately 2/3 of all the sodium reabsorbed in the kidney. An important thing to remember in this area is the effect of angiotensin II, which stimulates the sodium proton exchanger, leading to more sodium absorbed and thus higher blood pressure. This is important because ACE inhibitors inhibit this process, leading to some loss of sodium and ultimately lowering of blood pressure. Also, this segment is the site of action for carbonic anhydrase inhibitors, like acetazolamide. They prevent the secretion of protons in exchange for sodium, leading to net sodium loss and diuresis. Next comes the loop of Henle. This segment is important because it allows for solute reabsorption without isoosmotic absorption of water, and therefore it is the concentrating segment of the nephron. Specifically, the NKCC co-transporter absorbs 1 sodium ion, 1 potassium ion, and 2 chloride ions. This is a very important channel because loop diuretics such as furosemide inhibit this channel, leading to substantial diuresis with loss of sodium, potassium, and chloride along with water. This segment is also the site for magnesium and calcium absorption, which occurs paracellularly. The next segment is the distal tubule. Here, the major player is the sodium chloride co-transporter. This allows non-isoosmotic absorption of ions without water. This channel is stimulated by angiotensin II, leading to sodium absorption and increased blood pressure. It is also inhibited by thiazide diuretics, such as hydrochlorothiazide, which leads to sodium loss and diuresis. This segment also contributes to calcium reabsorption, and the cells respond to parathyroid hormone by increasing absorption of calcium. The last segment of the nephron is the collecting tubule. This is where urine can be diluted or concentrated. In response to ADH, aquaporins get inserted into the membrane and allow water to be reabsorbed by itself, thereby concentrating the urine. Also, this segment is the site of action for potassium-sparing diuretics, like triamterene, which act by inhibiting sodium reabsorption and promoting sodium loss and diuresis. This is also the site of action for aldosterone, which acts by stimulating sodium absorption and potassium secretion in order to increase blood pressure. Okay, that was a lot of important physiology on one page. As you move forward with your studying, please be sure to look back to this page in order to refresh your memory about the function of the nephron. It's really important to know for your exam, and it will make you shine in your clinical rotations too. But for now, let's go through some questions to drive things home. Ready? A 56-year-old woman who recently started therapy with furosemide complains of fatigue and muscle weakness. Her serum potassium is 3.2. Which clinical sign would you expect to see? Homan sign, Murphy's sign, or Chvostek's sign? This is a tough one. Even though you might have memorized what each of these signs are, you really need to understand how the nephron works in order to understand this question. Since furosemide is a loop diuretic, it inhibits the sodium-potassium chloride co-transporter. This leads to diuresis with loss of potassium, which explains her low serum potassium of 3.2. However, this would also interfere with the normally positive lumen potential in the loop of Henle, and thus would prevent absorption of calcium. So, this patient probably has hypocalcemia, and the answer would then be Chvostek's sign, because that's the one that's associated with low serum calcium. Just as a reminder, Homan's sign is a very nonspecific finding associated with DVTs, and Murphy's sign is associated with cholecystitis. Let's do one more question. Name at least 3 mechanisms by which enalapril, an ACE inhibitor, contributes to lowering blood pressure. This question really shows you how intricate the kidney can be. Enalapril, which is an ACE inhibitor, prevents the formation of angiotensin II. This has a number of important effects. First, angiotensin II normally acts in the proximal tubule to stimulate sodium absorption in exchange for protons. Less angiotensin II will lead to sodium loss in the urine, and since this happens isosmotically, it will also lead to water loss and subsequent lowering of blood pressure. Second, angiotensin II normally acts in the distal tubule to promote sodium absorption by cotransport with chloride. So, an ACE inhibitor will also lead to more sodium loss and diuresis in this segment of the nephron too. Third, angiotensin II normally stimulates aldosterone production. Aldosterone in turn acts in the collecting tubule to reabsorb sodium. So less angiotensin II will promote sodium loss and resultant diuresis via less aldosterone. In fact, angiotensin II has even more effects on lowering blood pressure, which we will get to in a few minutes, but you can see that an understanding of the nephron is really important to get a handle on how some antihypertensive drugs work. Now that we've gone through the nephron in great detail, let's move on to see how its function affects various solutes. Here we have a graph of relative concentration of various solutes along the proximal tubule. X-axis is the percent distance along the proximal tubule, and the y-axis is the ratio of tubular fluid concentration to plasma concentration. The gray shaded area includes all substances that have net reabsorption, and the yellow shaded area includes all substances that have net secretion. There are a couple of important points to take away here. First, the vast majority of substances have net reabsorption in the proximal tubule. Second, the TF to P ratio can tell you how quickly something is absorbed relative to water. For example, glucose is absorbed very quickly in the proximal tubule, and much faster than water, so it's completely gone by the end. On the other hand, chloride is absorbed slower than water in the proximal tubule, which makes sense since most chloride is absorbed later on in the loop of Henle and the distal tubule. One important special case is sodium, which is absorbed at roughly the same rate as water, since water absorption in the proximal tubule is isoosmotic with sodium. This graph tends to be very high yield on the exam, and if you understand how the proximal tubule works, you shouldn't have any trouble filling things in. For example, why does the line for inulin increase steadily over the course of the proximal tubule? Well, since inulin is freely filtered, but not reabsorbed, the amount of inulin in the tubule remains constant, but water is being progressively absorbed with sodium, so the concentration of inulin gradually increases from beginning to end. Again, please use this graph as a reference during your studying. Now we're going to shift gears and talk about some of the hormonal functions of the kidney. We'll start with perhaps the most important, the renin-angiotensin-aldosterone system. The main function of this system is to regulate blood pressure, and the best way to walk through this diagram is to think about how all this fixes low blood pressure. Suppose a patient has been injured and has lost blood, so that his blood pressure is now 95/70 instead of 120/80. How would his body respond? First, the drop in blood pressure has to be detected. There are a number of ways, but the main one is the juxtaglomerular cells, or the JG cells, in the distal tubule of the nephron that sense lower renal perfusion that results from low blood pressure. Then, the body has to respond to low blood pressure, and the JG cells do this by secreting renin. Renin then acts to convert angiotensinogen, which is secreted by the liver, into angiotensin I, which then gets converted by angiotensin-converting enzyme, or ACE, into angiotensin II. We've already talked a little bit about angiotensin II. It's a broadly acting hormone that has a lot of effects to increase blood pressure. It acts directly on vasculature to produce vasoconstriction. It also constricts the efferent arteriole of the glomerulus to preserve GFR. It directly stimulates proximal tubule sodium absorption, and it stimulates the hypothalamus to produce thirst. As if that wasn't enough, it also acts to produce two other hormones that increase blood pressure. Aldosterone, made by the adrenal gland, which enhances sodium and water absorption in the collecting tubule, and antidiuretic hormone, or ADH, made by the posterior pituitary, which stimulates direct water reabsorption in the collecting tubule. All in all, there are 6 different mechanisms by which angiotensin II increases blood pressure, directly or indirectly. There are some further specifics to the system which we won't go over here, but you should already have a sense for how important the system is. That's why taking a drug like enalapril, which is an ACE inhibitor, is such an effective way to lower blood pressure, because it makes all 6 of these pathways less effective. We'll talk more about this class of drugs near the end of the lecture.